So let's move to the next presenter, Dr. Benjamin Liu will be presenting on comparative analysis of outcomes of endovascular aortic repair and aortobifemoral bypass for aortoiliac occlusive disease from University of Missouri.
All right, hello everyone. I'd like to thank the Society for giving us the opportunity to present our work. My name is Benjamin Liu. I'm a third-year medical student at the University of Missouri. We can go ahead and get started. Here are our disclosures. So as some background, as we all know, there's aortoiliac occlusive disease, AIOD, can be significantly limiting to our patients. For those who require surgical intervention, the historical option has been placement of an aortobifemoral bypass. However, in recent years, there's been an increasing use of placement of unibody endografts to actually treat this condition. There have been some small case series studying the outcome of this endovascular approach towards treating aortoiliac occlusive disease. However, comparison against traditional therapy is lacking, so we believe further research in this area is appropriate to help determine optimal approaches for these patients. So what we've done is conducted a retrospective study on patients at our institution. We took a look at patients with aortoiliac occlusive disease who have been treated surgically, either with placement of a unibody bifurcated endograft or an aortobifemoral bypass. We collected demographics and anatomical characteristics as well as evaluated outcomes to compare the two approaches. What this resulted in was 133 patients with complete data, which we then narrowed down to 82, who had aortoiliac occlusive disease as their primary indication for intervention. And what this results in is a cohort where 26% had received a unibody endograft, whereas 74% had received an aortobifemoral bypass. We classified iliac lesion severity using the TASC criteria. As you can see on the right there, we found significant differences between the patient populations treated with unibody endograft compared to ABF, with 86% of patients receiving a unibody endograft with a TASC classification of A or B, whereas in the ABF group, only 36% of those patients had a TASC classification or A or B type lesions. We additionally found a statistically significant higher prevalence of diabetes in our patients who received a unibody endograft as well. When we take a look at our perioperative values, it's a bit of a large chart, I apologize, but there's some significant findings that we wanted to present. First of which is ABIs, which we found significantly different between ABF and unibody. We found that for our unibody group, they tended to have higher pre-op ABI values compared to ABF, whereas post-operatively, the unibody group actually tended to have lower ABIs compared to ABF. On average, we also found that the size of the iliofemoral arteries were larger in our unibody group compared to ABF. And perhaps as expected, for patients that underwent ABF, surgery times were longer and estimated blood loss was higher as well. We just wanted to put a slide to kind of illustrate the types of adjunct procedures these patients were receiving at time of operation. 48% of our patients receiving a unibody endograft and required endarterectomy at time of operation, whereas 13% of our ABF procedures required some form of adjunct procedure, whether that be an endarterectomy, thrombectomy, or in one specific case, an additional bypass graft being placed at the time. When we look at our univariate outcomes and we look at our cohort as a whole, we found that 19.5% of our cohort required reintervention after a graft was placed, whether that be unibody or ABF. However, when we split that into groups from our unibody and ABF, we find that there is no difference in reintervention between placement of a unibody or an aortobifemoral bypass. Similarly, when we take a look at our 30-day outcomes, such as mortality, stroke, or major adverse cardiovascular event, we again see no difference in outcomes between the two approaches. Finally, we also see no difference in occlusions for patients that received a unibody versus ABF. Illustrated here are the types of reinterventions that these patients groups received. 24% of our unibody procedures required a form of reintervention, compared to 18% of our ABF procedures requiring a form of intervention. When we take a look at our cohort split by patients that required a reintervention versus the ones that did not, we find that there is smaller iliac SFA and PFA artery sizes associated with our reintervention group compared to our non-reintervention group. When we also split our cohort by gender, we find that there is a trend towards lower ages and more severe iliac task classifications for our male patients compared to female, and we found a statistically significant smaller sizes of the iliac, common femoral, and superficial femoral arteries in our female population. We then ran logistical regression on 4 of our outcomes to identify predictors. We ran them on occlusions, mortalities, reintervention, and leg ischemia. A statistically significant result was seen in our reintervention model, where there was an association with higher risk for reintervention with smaller artery sizes. When we take a look at our patency data at 36-month follow-up for these population groups, we see that there is no statistically significant difference in primary patency for patients treated with a unibody endograft compared to those treated with aortobifemoral bypass. Similarly, for secondary patency, we see similar results for both approaches as well. And finally, when we look at survival analysis, we see that it's 36-month follow-up. There is no statistically significant difference between those treated with unibody endograft and those treated with aortobifemoral bypass. So, conclusions to take away from our study today are that there are equivalent outcomes seen between use of unibody endograft and aortobifemoral bypass for our patients with aortoiliac occlusive disease. This is reflected in similar outcomes in terms of stroke, major adverse cardiovascular events, as well as in midterm outcomes such as patency and as well as survival. We found no gender difference in outcome other than, again, that association with smaller artery sizes with our female patients. And we did also find that smaller artery sizes were independently associated with increased risk for reintervention for these patients. Finally, the best option for approaching task C or D type lesions still remains relatively unclear, as in our study, a comparatively lower amount of patients with these types of lesions were treated with an endograft. That concludes my talk. Thank you.
So we have Dr. Coleman.
Hi, good afternoon. Dawn Coleman from the University of Michigan. I enjoyed your presentation, and I think it supports some biases that most of us might have. It's a retrospective review, and kind of at face value, your opening results slides would suggest that you had kind of 2 different cohorts or populations of patients when you think about their anatomic disease burden and blood vessel size, as an example. So my questions for you are really twofold. The first is, did you adjust for these things as you considered your primary endpoint and your secondary endpoints? My second question for you is, acknowledging the differences between your 2 comparative groups, how is the decision-making being made presently when you consider these patients that have been treated over the last 5 years? And how does this data impact or translate into care at your institution moving forward? Thank you.
Sure, those are great questions. I think I'd defer to my senior author on how it's impacting
I had a
care.
feeling you would. So, all right, so, I'll be honest, okay, it's a difficult thing to put out there because they are different, but I think it's important to look at it. And we don't have 150 in each group. And if you look in VQI or any of their databases, you're not going to be able to answer the question. So, number one, I would say this is a great call for us actually to try and pull data and look at this in a proper manner. That being said, for me, this is more of a sort of compelling argument that aortobifemoral bypass graft still remains in an important tool in our armamentarium. I would say, although one can perform endografts, and I know there's some people that don't perform any aortobifemoral bypass grafts anymore, I still think there's a good role for this operation. The patients had similar outcomes despite a higher task classification. They didn't die with more frequency than the other group. There were no differences in the comorbidities between the groups, yet the aortobifemoral bypass patients who had a more severe anatomic task classification did as well in sort of 36th month and even at 60-month data. So I appreciate there's a lot of limitations in this. We're going to write this paper very carefully and obviously look at these things. When you're looking at 22 patients versus 60 patients, doing subgroup analyses and sort of trying to propensity score match them and things is really difficult. However, I still felt that it's like sort of start this debate and talk. stay tuned, stay tuned.
Dr. Rowe?
Oh, thank you, and you're to be congratulated first for your mentorship of your student. He did a great job, and also for putting this together. You're right, it is still unclear. I have about 4 to 5 of these patients, and the real key for the decision making was, do I do this, do I do an aggressive endo, or do I do an Axbifem? I still think if they can handle an Aortobifem, that is the gold standard, but I thought it was really between this and an Axbifem. My one question was, I thought I saw that 15 patients had prior aortic interventions in your database, and so what were those interventions that the patients had?
15 patients with aortic interventions. I think that the type of interventions that would happen for this patient database were typically aneurysmal in terms of nature, but Dr. Bath, if you call.
Yeah, I'll be honest, Dr. I'm going to have to look back at that. When we were sort of looking at this, I think it really is aortoiliac interventions and really should probably be classed as such. I imagine, and I'll have to look at those 15 patients, those 15% are probably iliac stents and things like that. So, but yeah.
Okay. We're going to have to move on to our last one before the break here.